Welcome everyone to Benefit Considerations, Medicare and Group Health Plans. Thank you all so much for joining us. Our moderator for today's call is Beth Allen. She will be answering the questions you send through the Q&A today. We will try our best to answer all of your questions, but if for whatever reason we are unable to get to your question today, please follow up with your advisor for further assistance. Today's presentation is being recorded. We will be sharing the recordings in the follow-up email on the NFP website. If there are any portions of this call that you missed, by Friday, you will receive an email with a link to the full recording. The PowerPoint slides used during this presentation will be shared in the same email. At this time, I'd like to introduce our speakers for today's webinar. Joining us today are Diane Cross, Vice President and Counsel of Benefits Compliance at NFP, and Patrick Myers, Vice President and Counsel of Benefits Compliance at NFP. We are very excited to have them speaking with us today. It is my pleasure to hand the call over to our speaker. Patrick, the floor is yours.
Thank you so much. Good afternoon, everyone, and welcome to our presentation on benefits considerations when it comes to Medicare and group health plans. Don, if you can go to the next slide. So our disclaimer here is that, of course, this is not intended to be legal advice. This is just for general information. And the information that we're going to be giving you today is current as of today. Also want to point out that we're not experts in Medicare, and we're only going to be touching on those issues those areas where Medicare bumps up against group health plan considerations. And also everybody's experience with Medicare is different. And so if there are specific questions that we cannot answer here or do not address here, we encourage you to consult with counsel. And these are our smiling faces, all of this and knowledge too. And hopefully we'll be able to highlight some aspects of Medicare that bump up against benefit health plans over the course of the next hour. Next slide, please. So on our agenda today, we're going to talk about Medicare eligibility in general, and then we'll move on to Medicare Secondary Payer rules, which is really where the rubber hits the road for most of us when it comes to Medicare and group health plans. And within that, we'll be talking about coordination of benefits and some of the other requirements that are ancillary to the secondary payer rules. When we're done with that, we'll move on to interactions with other laws, such as HSAs, the Section 125 qualifying events, and COBRA. Then we'll talk about some reporting and disclosures, issues, and requirements, and then wrap it up with some additional considerations. So let's begin by talking about Medicare eligibility in general. Next slide, please. The main federal agency that deals with Medicare, of course, is CMS. The Social Security Administration is also involved in this process to the extent that, as we will talk about a little later, when you obtain or enroll in for Social Security Administration benefits, you're automatically enrolled in CMS Medicare, and so they have a secondary role in this process. Next slide, please. When we talk about Medicare, there are actually four parts of Medicare, parts A through D. Part A and B are what we call original Medicare, and Part A handles the hospital coverage and related coverage, and you automatically enroll in Part A when you obtain Social Security benefits, and you don't usually pay a premium for Part A. Part B is the outpatient services part of Medicare, of the original Medicare. This covers doctor and clinical labs, outpatient and preventive care, screenings, and so on. There is a premium for Part B, and the standard premium for this year is $148.50. It changes year to year. Part C is the Medicare Advantage part, and this is usually administered through a private insurer. It usually gives you a combination of Parts A and B, and often will also be combined with Part D. The premiums for Part C will vary by plan, and that will depend on how the insurer has negotiated prices with providers and other cost-cutting measures that the insurer may have imposed on the system in order to keep premiums down. And then finally, Part D is the prescription drug plan. It's a standalone drug plan, but it can be combined with Part C, as I've mentioned. And again, the premium for this part also varies by plan. Next slide, please. So in order to be eligible for Medicare Parts A and B, one of four things should apply. First and most commonly, if you are 65 and you're receiving Social Security or railroad retirement, you are eligible for Medicare Parts A and B. And in fact, if you've obtained and enrolled in Social Security, you're automatically enrolled in Part A. If you have Lou Gehrig's disease, you are also eligible for Medicare, as well as Social Security disability and end-stage renal disease. Next slide, please. If you're 65 and over and receiving Social Security or railroad retirement, like I mentioned, it is often automatic, but it's not always automatic. Again, it's automatic only if you are receiving those benefits from the Social Security Administration or the railroad retirement. If you're not receiving Social Security at 65, then you don't have to enroll in Parts A and B, and you can wait to apply for those later. And we'll talk a little bit about that later as well. Next slide, please. So when you become the initial enrollment period for Medicare's Part A and B occurs or begins 3 months before you turn 65. And then it goes on through the month that you turn 65 and then continues through 3 months after you turn 65. And this, of course, is called the initial enrollment period. It's a 7-month period, and this will be the first shot at enrolling in Parts A and B. Now, again, you don't have to enroll during this period. If you are already working or you're not, if you're still working and have group health plan coverage, you're not required to enroll in Parts A and B. And we'll talk a little bit more about it a little bit later. But this is the first shot at enrolling in Parts A and B. Next slide, please. So there's a general enrollment period, much like in other insurance contexts, and it goes from January 1st to March 31st every year. If you didn't enroll during that initial enrollment period, and you're not eligible for a special enrollment period, which I'll talk about in a minute, then this would be the time to enroll in Parts A and B. If you enroll during this period, then your coverage under Medicare will start on the 1st of July of that year. Next slide, please. The special enrollment that I mentioned earlier occurs if you have delayed in enrolling in Parts A and B, but then you lose coverage and you need to enroll in Parts A and B after that. That occurs, and the special enrollment period, is an 8-month period that occurs starting on the date that you have lost the coverage under your group health plan. If you work for an employer that provides group health plan coverage and employs over 20 employees, then you can choose to delay coverage without penalty. If, however, you delayed coverage and you didn't enroll during the 8-month special enrollment period, then you may be subject to a late enrollment penalty for the premium in Part B, as well as incidentally in Part D, which would kick in if you fail to enroll in Part D after you've lost coverage, group health coverage for drug coverage, under your group health plan. Next slide, please. So now we'll move on to the where the rubber hits the road in our talk, which is the Medicare Secondary Payer regulations. If you go to the next slide, please. There's actually a collection of ideas or concepts that are kind of under this umbrella of Medicare Secondary Payer. There is, as you can imagine, the coordination of benefits component, which is the big one. But there's also a concept called taking into account Medicare entitlement. And this concept basically kicks in and prohibits group health plans from taking into account the fact that a participant is entitled to Medicare when it interacts with that participant. For instance, things like charging a Medicare entitled individual a higher premium because they are Medicare entitled, or requiring a Medicare entitled individual to wait longer for coverage to begin just because they're entitled to Medicare. Those kinds of things are prohibited under the Medicare Secondary Payer rules. Now, there's another prohibition, or rather requirement, I should say, under the MSP rules, and that is the same benefits under same conditions idea. And that is people who are participants in a group health plan who are 65 or older must have the same benefits and under the same conditions as those participants who are under the age of 65. And then finally, under the MSP rules, group health plans are prohibited from offering certain incentives. And that means that a group health plan cannot discourage Medicare eligible employees from enrolling in their health plan or encourage the employee to drop the health plan so that they can go into the Medicare plan. So if you go to the next slide, we'll see that under the coordination of benefits idea, the Medicare Secondary Payer rule, Medicare pays second. But which employers have to comply with these rules and which don't? It kind of depends on whether or not the Medicare is age-based, disability-based, or otherwise. If we're talking about age-based Medicare, that is, if you're 65 or older, then the Medicare secondary rules apply only to group health plans of employers with 20 or more employees for each working day in at least 20 weeks in either the current or the preceding calendar year. Now, if it's disability-based, then they apply to employers with 100 or more employees, whether full-time or part-time, on at least 50% of its regular business days during the previous calendar year. Now, the small employer exception, that is, employers with 20 or fewer, with fewer than 20 employees, that does not apply for those who qualify for Medicare because of ESRD. This will apply regardless of the size. And under the MSP coordination of benefit rules, Medicare generally must be the secondary payer for the first 30 months of an ESRD patient's Medicare eligibility, but then it will be primary after that. So the next slide, please. So this slide provides an overview as to when the group health plan is primary and when Medicare is secondary. So if you have an active employee and you have coverage under their plan, the primary plan will be your group health plan and secondary plan will be Medicare. This is, of course, when you have 20 or more. If you've got an active employee who has or with spouse with a Medicare that's due to disability, which is, you have an employer with 100 or more employees, the group health plan is still primary and Medicare is secondary. If you're a COBRA participant with Medicare, then Medicare will be primary and the COBRA will be secondary. Now, this is because the COBRA plan is not considered to be active group health plan coverage. So that will be secondary to the Medicare in this case. Now, if again, as we mentioned before, if the participant has end-stage renal disease, then the group health plan will be primary for the first 30 months, but then will become secondary to Medicare after that. Next slide, please. So again, you cannot encourage or provide an incentive for Medicare eligible individuals to terminate group coverage. And such individuals must be eligible for the same benefits under the same terms and conditions as individuals under age 65. And you can't take into account the fact that an individual is Medicare eligible due to age when you are affecting the relationship, that individual's relationship with the group health plan. Next slide, please. So let's go through some scenarios. In our first scenario, ABC Company has 75 employees. As a cost-saving measure, it decides to exclude from group health plan eligibility all employees aged 65 and older, since they are eligible for Medicare and have another option. So is this permissible under the MSP rules? No, because the employees aged 65 and older must be eligible for the group health plan under the same terms and conditions as other employees. Now, in the next scenario, XYZ Company has 47 employees. They have several employees who have waived group coverage to go on Medicare. It was a cheaper option for the employees, and it saved the employer money. XYZ wants to help these employees pay for Medicare coverage or for a supplement. It seems only fair since the employer contributes to the cost of coverage for the other employees. Is this permissible? No, because an employer cannot encourage or incentivize a Medicare eligible employee or spouse to drop group coverage. because that would make Medicare primary and violate the MSP rules. The contribution toward the cost could be seen as an incentive, which, as we mentioned, is also prohibited. So when you're designing the plan, here's some red flags to keep in mind to make sure that you don't run afoul of the MSP rules. First, a red flag is excluding employees or spouses who are 65 and older from the group health plan. Also, you should watch out for offering one plan to employees below age 65 and a different plan for those age 65 and over. Paying or reimbursing Medicare or supplemental premiums is also a red flag. And finally, charging employees different premium contributions based on Medicare enrollment or eligibility is also an issue under MSP rules. Next slide, please. So what can you do? You can exclude coverage for all spouses that will not run afoul of the MSP rules. You can offer any eligible employee a cash amount, which would be taxable, for opting out of the group health plan. And there are some issues there with interacting with the employer mandate for large employers that you need to keep in mind, but this will not violate the MSP rules. And also, offering a Medicare supplement plan to retirees is also fine. Next slide, please. So COBRA and Medicare, we mentioned this briefly in a couple of slides ago, but Medicare is primary, COBRA is secondary under most circumstances. The prohibitions for taking into account Medicare for active employees coverage doesn't apply in this scenario because COBRA is not considered to be active employee coverage for this purpose. Now, most states permit carriers to pay secondary benefits under COBRA regardless of whether the participant is actually enrolled in Medicare. So in other words, the insured's benefits will be reduced according to what Medicare would have paid. Because of this COBRA scenario, this sort of thing is fine. Next slide, please. So I did mention some penalties for failing to comply. The penalties are potentially equal to 25% of group health expenses during the calendar year. There's a statutory penalty of $5,000 per incident. And if Medicare pays a claim that should have been paid primary by the group health plan, CMS is entitled to be reimbursed for the amount that the health plan would have paid. If CMS had to bring legal action to recover damages, then the agency is entitled to twice the reimbursement amount, or in other words, what we call double damages. So the penalties can be quite hefty if the plan fails to follow the MSP rules. Next slide, please. So now we'll move on to Medicare's interaction with other laws, and I will pass this over to Diane.
Actually, really quickly, Patrick, if you don't mind, we got a very astute question from someone in the audience that asked about whether or not the rules are similar to the Medicare Secondary Payer regulations as it pertains to TRICARE. Can one of y'all speak to that really quickly?
Yes, I believe that those do interact in a very similar manner to TRICARE.
You are correct with that. So there is actually kind of the same concept as far as TRICARE and an employer not necessarily being able to encourage people to get off of their group plan and go to TRICARE. But there are some differences in the application as it relates to TRICARE supplement plans. And so if you are one of those clients who has employees who are on TRICARE, you just want to make sure that the way that you are operating your plan is compliant. But thanks for taking that curveball. Go ahead, Diane.
Thanks, guys, and thanks, Patrick, for the background on general eligibility and Medicare Secondary Payer rules. While many of our Medicare-related group health plan questions will deal with those MSP rules, those Medicare Secondary Payer rules that you just went over, several also deal with how Medicare will interact with other benefits-related laws. So we're going to start this conversation of our presentation today on HSAs. And a quick refresh on HSAs in that to be eligible for an HSA or to contribute to an HSA, you have to have enrollment in a qualified high deductible health plan, not be a tax dependent of another, not enrolled in Medicare, and not have any impermissible coverage. For the purposes of our conversation today, we're highlighting that Medicare entitlement that's eligible and enrolled, and we're going to call this out here in just one second. But for frame of reference, and as Beth was just talking about, TRICARE is also an impermissible coverage for HSA as it relates to that. Medicaid, general purpose HRA or health FSA, certain circumstances, VA medical benefits could be impermissible coverage. And so that's just the general, oh yeah, here's the impermissible coverage for HSA being eligible to contribute. And for our purposes of today's conversation, Medicare entitlement is one of those enumerated impermissible coverages. And if you are entitled to Medicare, you are not eligible to contribute to an HSA. With most things benefits related, it's not as straightforward as it seems. So we're going to go through a few scenarios to elaborate on this topic. As we all know, high deductible health plans paired with HSA enrollment is very common benefit offering. So it's really important to understand how Medicare coverage will impact HSA eligibility. Now here's the blinking, don't forget. Several years into this industry, and it's always confusing for folks when we throw the term entitled to Medicare out. And we use that term because that's how it is termed in the regulations. But remember that entitled to Medicare simply means enrolled in Medicare. So we'll try to qualify that when we say entitled to, it means enrolled in. It does not mean just eligible for. Okay, so an employee enrolled in Medicare is not eligible for HSA contributions. An employee only eligible for Medicare but not yet enrolled is eligible for HSA contributions. Again, they seem straightforward, but I think those E words trip us up with Medicare, and we hear eligible for Medicare and sometimes think immediately pump the brakes with HSA eligibility, and that's just necessarily not always the case. So let's talk about that a little bit further. What are the key points that we want to take away today regarding HSA eligibility and Medicare? Ineligibility for HSA contributions begin the month the employee is enrolled in Medicare. This is something to give more consideration to than you would think, because retroactive enrollment after a 65th birthday will apply. And we'll talk about that here in a moment. But you can have retroactive enrollment for up to 6 months if somebody applies after their 65th birthday. And unfortunately, ineligibility for HSA will be retroactive those 6 months too. So the point being there is that it's really important for folks to understand these concepts on the front end to avoid any miscommunications or excess contributions that will need to be corrected on the back end. HSA eligibility is determined on a monthly basis. So what that means is somebody is eligible for Medicare and enrolls in Medicare mid-year, their annual contribution limit is prorated to correspond to the amount of months in which they were HSA eligible. So the month one turns enrolled in Medicare is the month in which the employee is no longer eligible to contribute to the HSA. So some math needs to be done too. And we're going to walk through all these concepts in a couple of examples in the next few slides. And then the other key point here is that excess contributions should be withdrawn by tax time. So these three big bullets are going to be discussed a little bit through examples, but the takeaways here that you want to think with HSAs and Medicare is that eligibility is determined on a monthly basis, and eligibility for HSA contributions begin the month the employee is enrolled in Medicare. That can be retroactive, and that any excess contributions should be withdrawn by tax time. So let's take a quick example. I learned best by examples, so we like to use those. Let's take Stephanie, who turns 65 in February, but continues to work and has group health plan coverage. So Stephanie is not enrolling in Medicare, and she is not automatically enrolled in Social Security. So she is still HSA eligible at this point, assuming she is otherwise eligible. But in February, she retires and starts drawing Social Security in January. And as we know from what Patrick mentioned, she's automatically enrolled in Medicare's Part A and B. In Part A as of July 1st, because we have a 6-month retroactive application. So that is how it comes to play, where you see that retroactive, we should have thought about this during the year, or we should have pre-planned, if at all possible, for this scenario. So that result, we see that scenario quite frequently, where folks will delay enrolling into Medicare until, retirement or termination at a later date, and there's a retroactive application of Medicare enrollment. So in this specific situation, Medicare is retroactive back to July 1st. What that means is that Stephanie can only contribute for the calendar year, 6 of the 12 months of the annual limit, so half the annual limit. Everything is fine if her contributions don't exceed her prorated annual maximum. But if they were in excess, she would have to correct them by tax time. Another big takeaway here, too, is employee education. While a lot of these errors can be corrected, they can also be avoided if folks understand how these rules interplay from the onset. All right, so let's go into some other key components on how does spouse's Medicare impact an individual's HSA eligibility. This is another frequent flyer question. So let's go over some key points in that the spouse cannot contribute to an HSA if the spouse is enrolled in Medicare. Why? Because the spouse is not HSA eligible if the spouse is enrolled in Medicare. That was one of the 4 main HSA eligibility components. However, sometimes at that point, it gets confused because you think Medicare, an employee who covers a spouse who's enrolled in Medicare, you pump the brakes and press the pause button. But note that the employee is still eligible for the HSA, and the employee, if enrolled in family coverage, can contribute the family maximum. And the employee can still reimburse the spouse's qualified out-of-pocket medical expenses. So that's good food for thought. Let's take all of these concepts in a couple of examples. Let's look at a mid-year Medicare enrollment. We have Michael, who has effective coverage January 1, but by April, Michael has already made the full contribution of $4,600, and that is $3,600, which is the 2021 annual maximum for self-only coverage, plus a $1,000 catch-up contribution. In August, Michael enrolls in Medicare. And the last bullet here is that in this situation, Michael will owe income tax and excise tax on his excess contributions. So let's walk that back a few steps. Michael, as we see, was eager, like a lot of folks are, contributed the annual maximum by April, but turns out he was not eligible 12 of 12 months. So his annual maximum contribution will be prorated for 7 of the 12 months. And for quick math, that comes out to be about $2,683 in change. That is his annual maximum. However, he already contributed $4,600. So what Michael will need to do is make a correction so he doesn't owe income tax and 6% excise tax on his excess contribution. And so the little note there explains that the excise tax will be avoided if those excess contributions and any associated interests are distributed out of the account by the tax filing deadline. Generally speaking, an HSA institution can assist with this, as can the individual's tax advisor. So I think we can see here how quickly it is helpful to know on the front end, so that in going back to Michael's situation, if he was educated on the front end, he could have been more purposeful in how much HSA contributions he was contributing if he knew he was going to enroll in Medicare later in the year, which a lot of employees sometimes know that. So let's look at another example with a spouse's mid-year Medicare enrollment. John is an employee at Acme Company, and he has employee plus spouse coverage in the employer's high deductible health plan. Him and his wife are over the age of 65, and every year John has been contributing the maximum family contribution plus his $1,000 catch-up contribution, and Jane opened her own HSA account so she can contribute her $1,000 catch-up contribution as well. But in 2021, Jane turned 65 and enrolls in Medicare effective August 1. So how does this scenario play out? So John remains eligible to continue. Sorry for that slip up, because I think we're confused at John's age, but that is not impacting on the guidance here. But John remains eligible to contribute to the family maximum contribution plus his $1,000 catch-up contribution. So that's what we said. We have spouses enrollment, but John is not enrolled. He's still enrolled in family level high deductible health plan coverage. He can contribute $7,200 plus his $1,000 catch-up contribution. Jane is no longer HSA eligible. She cannot contribute to the 12 out of 12 months for the catch-up contributions. Hers would be prorated 7 of the 12 months, and her expenses are still eligible for reimbursement from John's account. So the change here when the spouse enrolls in Medicare is that the employee, as long as the employee is still otherwise HSA eligible, they can continue to contribute up to the maximum and reimburse eligible expenses of the wife or spouse who is enrolled in Medicare. All right, so let's switch gears from HSA and Medicare to Section 125 in Medicare. As a lightning round refresh here, if the employees contribute to the cost of coverage on a pre-tax basis to Section 125 rules, that's when we get the cafeteria plan, synonymous with the term Section 125 rules come into play when benefits are taken on a pre-tax basis. Elections, as you may know, cannot be changed without a qualifying event. Generally speaking, they're irrevocable. Most often, plans are drafted to allow a prospective mid-year election change on the accounts of and consistent with a qualifying event. And the request has to be made by the plan's terms. And if the plan doesn't follow, or the administrator doesn't follow the plan document regarding qualifying event rules that are permitted regarding these mid-year election changes, the plan risks disqualification. So what are we trying to say here? All of those examples that we just went over are mid-year election changes. Somebody enrolls in Medicare. The next step is they may want to drop group health plan coverage. So a qualifying event, mid-year election change. What is permitted upon Medicare enrollment? You can drop the respective individual who enrolls in Medicare. That is consistent with this event. What is not consistent is dropping another covered individual who is not enrolled in Medicare. That's not consistent. It would not be a consistent election change to add the employee, spouse, or dependent child. So the point we're making here is I think we're all privy to those questions when there's a qualifying event happening mid-year on what changes can exactly be made. So here, think it needs to be consistent with the event. If an individual enrolls in Medicare, they can drop that coverage, but you could not drop another's coverage if they weren't also impacted by the Medicare enrollment, or i.e. enrolled in Medicare, and you couldn't add dependents or add an employee or add a spouse. It wouldn't be consistent. So let's look at this in some practical application. We have John, who's employed by Acme, and John has employee plus spouse coverage under the group health plan for himself and his wife, Jane. Effective August 12th, Jane enrolls in Medicare. Plan terms require notification of a qualifying event within 30 days. John notifies his employer on August 22nd, 2021. Is John permitted to drop group health plan coverage for Jane? And I'm assuming, because everybody's on mute, that we're all shouting, yes, of course, that's what we just said. So a few things to note here. John notified the plan within the timeline permitted by the plan. If the change requested is consistent with the event, Jane's enrolled in Medicare, Jane wants to drop coverage. And then an added bonus fun fact here is that generally speaking, that change would be effective per the plan terms, right? And plan terms generally will say it's either date of notification or first of the month following. So that's why we have here, yes, we can make this change effective per plan terms. Generally, it will be date of notification or first of the month following, depending on the plan terms in that regard. But let's switch it up just a little bit. And now same fact pattern, but John wants to drop his coverage. And I'm sure we're all shouting, is this permissible? And we're all shouting, no, because that's inconsistent. Although he notified the plan timely, it's just not consistent with the event. And so in this instance, with this qualifying event, Jane would be able to drop coverage, but John would not. All right. So with that, let's move to how Medicare interacts with COBRA. Big takeaway here that you're going to pick up on in over the next few slides is that timing matters with Medicare and COBRA. It matters which came first. And this is often sometimes an if-then equation. If Medicare, then COBRA, then what? If COBRA, then Medicare, then what? So let's go over that. If an employee enrolls in Medicare before a COBRA qualifying event, so retirement or termination, so you have Medicare first, then a COBRA qualifying event, and you enroll in COBRA, COBRA must be offered. If Medicare first, then a COBRA qualifying event, an offer of COBRA must be made. Let's say if an employee enrolls in Medicare after a COBRA qualifying event, COBRA coverage can be terminated only if it's a matter of plan design. So it's plan terms that state that COBRA coverage terminates upon Medicare enrollment. This needs to be administered per plan terms, applied consistently, and keep in mind that this would only affect the individual. What we mean by that is that if somebody is on COBRA and a spouse and a dependent is also COBRA qualified beneficiaries, this termination because enrollment in Medicare after COBRA would only terminate COBRA coverage for the affected individual. Okay, so again, the big takeaway here, if Medicare first and then a COBRA qualifying event, COBRA is offered. If you enroll in Medicare after being on COBRA coverage may be terminated per plan terms when applied consistently. Now here's a special rule, and it is appropriately titled Special Medicare Extending Rule. And this is really honing in on the fact that timing continues to matter as it relates to Medicare and COBRA's relationship. When a covered employee's qualifying event occurs within the 18-month period after the employee becomes entitled to Medicare, which we all now know means enrolled in Medicare, there's an extending period of 36 months for the spouse and dependent children. This extending period is measured from the date the employee becomes enrolled in Medicare. The qualifying event has to be termination or reduction of hours, and the employee will remain entitled to 18 months of COBRA. So there's a lot of moving pieces and different math. So let's look at an example on how this applies. We have Glenn working for Tower Car Wash. He has employee plus spouse coverage for himself and his wife, Clara. On September 1, 2020, Glenn enrolls in Medicare. He keeps his Tower Car Wash group plan as well. On May 31st, 2021, Glenn terminates. Are Glenn and Clara eligible for COBRA? Yes. Both are eligible for COBRA beginning June 1. This is because Medicare came first and then the COBRA qualifying event. Clara is eligible, though, to continue for 36 months, but this is counted from September 1, 2020, the date Glenn enrolled in Medicare. And then Glenn is eligible to continue for 18 months, counted from June 1, 2021. So as you can see, a pause should be made when we're dealing with the extending rule for spouses and dependent children. Sometimes there's confusion as it relates to the relationship between Medicare and COBRA on when the spouse and employee will receive, or the spouse and dependent would receive up to 36 months. But it is when a covered employee's qualifying event occurs within that 18-month period after the employee becomes entitled to Medicare. So here we have some reminders, and this should be blinking to extra emphasize these important points. That the individual has 8 months following the termination of active coverage to enroll in Medicare. COBRA does not delay the special enrollment period. So oftentimes, this is another really good example of how education can be helpful. Oftentimes, folks will think because they're enrolled in COBRA coverage, they don't think about enrolling in Medicare timely. And when they get to enroll in Medicare, they may face late enrollment penalties. So an individual has 8 months following the termination of active coverage. COBRA does not toll that. However, on the flip side there, COBRA does for prescription drug coverage and it for purposes of creditable status, which we're going to discuss here momentarily, an individual can delay Part D enrollment. So the good takeaway here is currently, COBRA does not delay the special enrollment period. So folks, it's really helpful for individuals to be educated so they can make purposeful decisions and not have some disgruntled employees on the back end. So with that, we're going to switch some gears to Part D creditable coverage disclosure and notice. And with that, the first step that we think about with creditable coverage is the plan's prescription drug coverage creditable? What do we mean by that? Does it pay on average as much as Medicare prescription drug coverage? So what does that mean? And there are a few ways to actually make the determination. And for purposes of this conversation, we are not going to take a deep dive on this, but there is a simplified determination and there's an actuarial determination if simplified determination does not apply. Generally speaking, if you sponsor a fully insured group health plan, the carrier should tell you this determination. If you are self-funded, generally speaking, the determination needs to be handled by the plan sponsor of the self-funded group health plan. Often TPAs or ASOs will assist in that regard as well. So with the simplified determination, the deductible should be no greater than $250 and pays on average 60% of expenses and provide coverage for brand and generic prescription drug coverage. So it's a very high-level overview of that. And then, of course, if that is not an option, there can be an actuarial determination as well. Now, one thing we do want to point out here is that high deductible health plans on their own rarely qualify as creditable, but keep in mind that HRA contributions are included to help with that creditable status, but it health FSA and HSA contributions are disregarded. So those are things to keep in mind. But what we really want to focus on here is the plan sponsors or the employer's responsibility to disclose. And there are two requirements, and this is often a miss. Sometimes folks are aware of one or the other, but some aren't aware of both. The two requirements are disclosure to CMS and a notice to eligible employees. So let's first talk about this disclosure to CMS. Employers of all sizes that offer prescription drug coverage have to make this disclosure. It's done electronically. That is the only way to do it, and it's done online via notification to CMS regarding creditable coverage status of a group health plan. We have the link in our slides, which will be shared after the presentation. If you have not made disclosure to CMS, it is a very straightforward electronic form with demographic information of the employer, selecting the option of the plan, whether it's creditable, not creditable, some creditable, not creditable, and submit. And this is done within 60 days of the beginning of the plan year. So a couple of best practices that we would advise when it comes to disclosing to CMS is to create a log when this happens. It's the employer's responsibility to file this. And we often get questions, whether there's HR turnover or somebody is doing a new position or what have you. We will get the question on, is there a way to see if we have filed this? Have we submitted this to CMS? And right now, we're unaware of any mechanism to check that status. So a best practice tends to be to create some sort of log or a system where you can note easily when and who or how it was done, not how it was done, so you can only do it electronically, but noting when it was done, so for future reference, there isn't that open-ended question on if this has happened in the past. So like I said, there's no database right now to go through and check to see if this has been done. And then the second notice is the notice to eligible participants. And employers of all sizes that offer prescription drug coverage have to provide this notice. And it is to notify eligible participants of the plan's creditable status. This has to happen annually prior to October 15th and to folks who are newly eligible. And then you would notify as well if the status changes. This should happen to all eligible employees, and that is the best practice. The requirement actually is to distribute to all Medicare Part D eligible individuals that are eligible for group health plan coverage. However, that can create some administrative difficulties in trying to pinpoint those folks. So as a rule of thumb, best practice, it's to blanket distribute the creditable disclosure. It seems easier to administrate that way, and you're crossing your T's and dotting your I's. And how do you do this? CMS provides a model notice, and it can be distributed by hand, mail, or electronically in compliance with the DOL's electronic notification rules. And don't forget to include COBRA participants in this distribution. So keep in mind, or it's good to keep in mind that there is no failure to comply with the Part D disclosure and notice requirements. However, there are a few noted penalties, if you will, for lack of a better term, that an employer with a retiree prescription drug plan could not claim the retiree drug subsidy. And that the issue here that comes in for employers who may fail to do this would be employee relations issues if employees aren't properly notified and later have a higher premium due to it. So an employer claiming retiree drug subsidy can only qualify if Part D eligible individuals are provided with a compliant disclosure notice, and then employees who go later apply for Medicare prescription drug coverage thinking they have prescription creditable prescription drug coverage, and in fact did not and weren't notified of it, will have some issues with the employer because it'll result in higher premiums if there was a gap of creditable coverage and the employee was not notified. So those are the penalties, if you will, for while there's no stated percentage or excise tax or what have you, those are the issues that come in with non-compliance. All right, so to hone in on how that would impact the employee, consider that a Medicare eligible employee who delays Part D believing that the plan is creditable, it's not. The employee would pay a penalty when he enrolls in Part D, and that penalty is 1% of the national base premium times the number of months that a person didn't have creditable coverage. And it stays with them. That's the penalty and the premium amount for the entire time enrolled in Part D coverage. So it can get pretty significant pretty fast. Let's switch gears on Part D, creditable disclosures and notices, to Section 111 reporting. Now, since 2009, to assist CMS in determining coordination of benefits, there is reporting required under Section 111. The responsible reporting entity, or the RRE, is the one who does this quarterly reporting. Generally speaking, this does not end up being the plan administrator, but it can be. For an insurer, it's the insurer for a fully insured plan, the TPA for a self-funded plan, but it will be the plan administrator for a self-funded plan that self-administers. So what is reported and when is it reported? The RRE has to file quarterly electronic reports with the CMS, and this includes enrollment information and Social Security data. What it does here is it enables Medicare to correctly pay for health insurance benefits of Medicare beneficiaries by determining that primary versus secondary payer responsibility. So that's what we mean by saying assist in determining coordination of benefit responsibilities. And what happens is the RRE submits a file of information regarding employees and dependents who are maybe Medicare beneficiaries with employer group health plan coverage that might be primary to Medicare. And in response, CMS provides the RRE with Medicare enrolled information for those individuals in the group health plan. And again, the goal here is that claims are paid per the Medicare Secondary Payer rules that Patrick went over and the proper coordination of benefit supplies. Now, what are the penalties for failure to comply with Medicare Section 111 reporting? Here there are defined penalties, civil penalty of $1,000 per day per individual not reported. That's significant. In addition to any penalties for claims paid by Medicare that the plan should have been paid by the plan. So that's a big deal. In addition to Section 111 reporting, we do want to discuss briefly the CMS data match. And so what is this? This is a process used by CMS to help administer those Medicare secondary payer rules and determine whether Medicare or group health plan should be primary. And what happens here is that the employer receives a request on a specific individual, and the request for a specific period of time frame and plan enrollment information. And then the employer provides an electronic response. So let's look at this on a timeline here. We have the Social Security Administration providing IRS with a list of Social Security numbers of those enrolled in Medicare. And the IRS will cross-reference that list with tax returns of individuals who received income from an employer. The IRS then forwards that information to CMS, and CMS reviews, identifies those with Medicare claims, and then CMS will contact an employer to determine whether the individual was enrolled in employer group health plan coverage. So that's a heads up for those who have never received this notification, and an aha if folks have dealt with this in the past. But keep in mind here, employer response is required within 30 days of receipt. There is a civil penalty of up to $1,000. You could be subpoenaed for business records, and an excise tax can apply. So this is something to not disregard and have a timely response to. Again, the goal is to coordinate those Medicare secondary payer rules, coordination of benefits. All right, so with that being said, let's conclude with a couple of key employer considerations. First, don't assume that you know whether a person's entitled to Medicare. As we said throughout the presentation, a best practice, specifically for the disclosures, is to blanket distribute so that you're making sure that you're fully compliant with the regulations. Educating the workforce is a best practice, especially as we're gearing up for open enrollment for group health plans and open enrollment for Medicare. Pay close attention to employee education and make sure it isn't seen as incentivizing. And understand, as Patrick went over, the Medicare Secondary Payer rules will prohibit incentivizing. Should proceed with caution, especially with those spousal surcharges and how they're applied. Be a stickler at open enrollment and understand that there are disclosure requirements, there are timelines that apply to those, and that education is particularly helpful, especially as it relates to enrollment into a high deductible group health plan that individuals will then enroll or intend to enroll in corresponding HSA coverage, and then fix mistakes quickly. So that is our presentation on benefit compliance considerations as it relates to Medicare and group health plan coverage. But I think we have about 90 seconds left. Are there any questions we should address?
Sorry, I was on mute. No, I don't think that there were any major questions that I think are outstanding. I think y'all did a great job of talking about Medicare. And I also think that kind of that last point you made just about the fact that, you can't really assume anyone's Medicare status. And so it's really hard, even as an employer, to necessarily give, information without, or with being able to know that what you are saying is correct for that person. I think if I had to end it out on one question, we did get someone who wanted to know, as it pertains to Medicare incentives, can they choose to offer a cash benefit to those that have coverage elsewhere? And if they do that, can they provide that to people on Medicare?
That's a great question, Beth. And so right now, IRS has given the informal information that as long as that cash is applied consistently equal to folks who are enrolled in Medicare and applied consistently to all folks, then it is not not compliant with the Medicare Secondary Payer rules. So I hope I'm saying that right. So as long as it's consistently applied and you're not singling out only Medicare eligible folks, it can be a compliant practice.
That is correct.
Anything you want to add there?
No, I think that's right. I mean, the way I explained it to the person that asked is just, if you have a cash in lieu of benefits design where everybody normally gets this, if you say that the Medicare people don't get it, then you're, again, singling them out, right? Which is kind of the spirit of this whole law, is that you should single out people on Medicare. So if everyone gets it, it's fine. At least that's the IRS guidance we received. That's all.
Well, thank you.
Thank you, everyone.
Amber,
Yes,
Amber,
thank
can
you.
close us.
Oh, thank you. Thank you, Diane and Patrick, for sharing your valuable time and expertise with us today. To reiterate, today's presentation was recorded. We will be sharing the recordings in the follow-up email and on the NFP website. If there are any portions of this call that you missed, by Friday, you will receive an email with a link to the full recording. The PowerPoint slides used during this presentation will be shared in the same email. At the end of this call, a survey will populate in a new window. Please take a brief moment to complete the survey, as it lets us know what topics are important to our listeners and helps make our education program as current and relevant as possible. That concludes our webinar for today. Thank you everyone for joining us and have a great day.